Hello, good morning, and welcome everyone who joins us. Today we are on the headquarters of the CISS, and it is an honor to greet our members of the panel of this conversation table about HIV and a stigma-free living. Here we have our Secretary General who will open this panel. The floor is yours. Thank you very much. And good day to everyone who joins us through the virtual platforms of the CISS. Of course, also in person, we are right on the headquarters of CISS, the Inter-American Conference of Social Security. We will talk about prevention that is stigma-free. We will talk about new tools for the early detection and preemption of the virus. From this standpoint, I would like to greet our members, especially in behalf of Mr. Zoe Robledo Aborto, who's the chair of the Mexican Institute for Social Security. We also have Mr. Herrera from the Sussex University. We have Dr. Ricardo Luque Núñez, who's the coordinator of sexual and reproductive rights of the Ministry of Social Security of Colombia. We have Mr. Leonardo Chanqueo, who's the Director of Prevention of HIV/AIDS. From the Ministry of Health of Chile, we have Dr. Steinberg, Director of the Canadian Reach Nexus. We also have the Director of the MedLabs Foundation of the Caribbean, based on Trinidad and Tobago, and Mrs. Nayeli Cardenas Garcia, who's the responsible of the medical devices area for the prevention of sanitary risks in Mexico. Thank you very much for being a part of today's activity, which is a panel. Today's event is brought by the possibility of creating HIV tests on the site that is most convenient to the user, which is more private and more comfortable. That eliminates several barriers to access related to discrimination and stigmatization. This is an approach that allows us to go to further cases that could otherwise go undetected. The objective of this panel is to provide a reflection and dialogue space to see the dialogues and self-testing of HIV. We hope that the conclusions guide us towards more effective strategies to improve the access to these tests and create a safe space. First of all, I would like to thank everyone, as well as the panel members, for their commitment, collaboration to create this space that is within the framework of the Social Security Week 2024, whose objective is to identify the best practices regarding sexual health and to see the areas of opportunities and get ready for the upcoming challenges that all social security institutions must tackle facing HIV and other issues. Facing 2030, the goal is to have a great percentage of the those living with HIV know their status. Thank you once again, and we hope you have a really productive day. Thank you. Thank you very much for your addressing. And we will begin the panel, and we will have Brandon Perez Gonzalez, Subdirector of the Exterior, who will present the members of the panel. Thank you very, very much, Technical Council and Secretary General. To our audience, this is available in English, Spanish, and Portuguese, so you can listen in the language that best suits you through Zoom and through the social media. This is the last panel of the Social Security Week 2024, and those who are with us in Zoom and have 80% of assistance to the different panels of these activities will earn a certificate of assistance. I want to explain to you that we have a brief division. First of all, Dr. Jaime Vera will kickstart the dialogue about self-testing of HIV around the world. Then each member of the panel will intervene during a maximum of 5 minutes to talk about the implementation in the regions or countries. Furthermore, we will have a discussion where I will moderate and give the floor to each of the members of the panel, and then we will close with conclusions and final thoughts by the COFEPRIS member in Mexico. On that regard, we will begin with Jaime Vera, and it is a pleasure for me to introduce him. It is an ally of us, and he has worked with us previously, and we thank him for doing that once again. He's a, he is part of the faculty of Brighton and Sussex University. He graduated as a physician and then got the specialty of internal medicine. Then he got a grant for research on HIV medicine in the St. Mary's University of the Imperial College in London. Then he increased his research and certifications in HIV. He researched the pathogens regarding inflammation in HIV with new imaging techniques. He is a consultant for Lausanne University of the Sussex Foundation Trust. He is working on the clinics on memory, HIV, and geriatry. He is part of the Roger Sussex County. Thank you very much, doctor, and the floor is yours. Thank you to the conference for having me and making me part of this event that is interesting for me and for everyone. Can you see the presentation on the proper format? Can you listen to me okay? Yes. Okay, I see familiar faces. I have Dr. Luke and Dr. Sean as well. So it is awesome to see them taking part in this. Today, I would like to talk about the implementation of self-detection for HIV, the opportunities and the challenges that we have ahead of us. First, let's talk a little bit about the context that we have towards the objectives to 95. From the global perspective, we still have ways to go, especially in the part of diagnosis of those who do not know their HIV status. So there's lots to do. If we see the trends of new infections as of 2010, we see that globally there has been a really significant advancement of a 38% reduction in new infections of HIV. However, in Latin America, the situation is static, and we have seen an increase of 8% as of 2010. So, on a global, on a regional scale, we need to work a lot so that everyone knows about their HIV status, so that they can receive treatment as soon as possible and they can receive constant treatment so we can avoid detection. We need to know what are the strategies to prevent HIV. The key that we need to have to get that 95% is to apply this type of strategies that we have proven evidence that they work, especially the pre-exposure prophylaxis or PrEP and the reduction strategies for the infection of those who inject drug, as well as voluntary circumcision. Those strategies are proven, but we know that the difference maker is the ability to know your HIV status and start receiving retrovirals as soon as possible because we know that if it is not detectable, it is not transmissible, and therefore the transmission is reduced, and that leads to the complete elimination of HIV. But if we think about where people go to make HIV tests, they go to clinics. This is the traditional way in which people receive clinical care, receive research tests and treatments. However, we have other ways. That's where the self-testing for HIV comes into play. And this has been a game changer for the HIV testing process in a significant way. What are HIV self-test kits? Well, it requires the user to make a self-testing, and if the result is positive, they need to go to make a second test to confirm the result and to receive proper treatment. The self-test kits can be with a pinch on the finger or with an oral fluid, which are the most common types, and they are commercially available. The result lasts 15 minutes, and if it is reactive, it needs to have a confirmation, and that's really important to tell the patients or those who use this type of products. HIV tests are currently on their fourth generation. They have an antigen and an antibody, and specificity and sensibility. We need to see how effective are these type of products. They have an effectiveness of 98% of sensibility and specificity, but we need to see the type of prevalence in the region. In areas where we have lots of prevalence, we will have few false negatives, whereas the contrary is true. But we need to find a balance of people having common tests, and if they have a positive test, they need to have a confirmation, and false negatives are harder to explain, but what matters is that they are doing constant testing. Now, what are the advantages of HIV self testing? We have privacy and confidentiality, and that is really important because that means that they can do the testing from home or wherever they think it is most convenient, avoiding the stigma related to visiting a healthcare facility and doing an HIV test when you actually ask for it. It is more convenient because people can do the test at will. It is empowering the people so that they take control of their sexual health and they can do this whenever they need it without the need to make any appointment or visiting any care provider. It is about the accessibility because this type of tests can be provided to people who cannot access to a healthcare facility. Think about someone who lives far away in rural areas. They can have access to this type of products without the need of having a medical center, an advanced medical center near you. It is really important in remote areas with limited infrastructure. But once again, I want to stress how important empowering people is so that they can take control of their own health. And after COVID-19, we've seen how important it is to empower people so that they can take their health in their hands in a different way than what had happened previously without their dependence on a medical care provider. But there are also disadvantages. Precision is a point of concern because depending on the prevalence of HIV, there is a risk, a small risk of false positive or false negatives, especially if the test is not done correctly. But also, we have a specific case that we've seen in cases with Africa, specifically in the Zambia, in which people, especially young people, tend not to believe in this test and they want the confirmation. So there's a lack of trust in the precision of this type of products. In reality, we are actually empowering people so that they can do the test themselves. It is limited because we don't have a counseling before the test is done, which is something that traditionally happened on clinics where healthcare professionals traditionally do this counseling process in case we have a positive. This has been eliminated with the self test. There is a small risk regarding psychological anguish, but it all depends on the information kits, on the intervention where the self test kits are being provided to the people. Also, limited availability because the HIV self test may not be readily available across all regions. So we have an issue of accessibility and equality regarding cost because we know that people need to pay out of pocket out of these tests. So this reduces the possibility of those who are struggling financially and are with an increased risk of HIV, they cannot access these type of products. Okay, this is part of the evidence that we have. The WHO has clear evidence on terms of the effectiveness of this type of products. And this is really important. I will switch a little bit of the slides. In terms of how they work and how they are implemented, let's talk about self-detection for HIV. In comparison with traditional HIV testing, we have an advantage in terms of self-detection. This is the evidence we have. This is a cluster of 14 randomized controlled types that show that HIV-VST doubled the uptake of HIV testing in the general population when compared to the standard HIV testing services. Also, this comes along the acceptance of this type of interventions, even in spite of the disadvantages I just mentioned. It is important then to understand this because one of the preoccupations that we have is that people actually do this by themselves. And the question is, how do they get related to the health services? But if information is right, and there is a way to access the HIV services and systems to get a treatment, then the patients that use the type of products are positively related to the services. So it is really important. This shows that this type of studies shows that they can have a really large impact as a strategy, both in HIV testing and in the reduction of stigma. I will give you the link later down the line for the report of the WHO showing some of the advantages of this type of products and the studies that back this information in this area. But the community factor is really important. This can be distributed through campaigns and events. We need to make the community become a part of this so that they can distribute this type of products. It is really important to give them in health centers and also through the internet. They can be sent through the mail and also we can have a secondary distribution effectively has been proven in Africa. I mean by partners and sexual partners to deliver the kits and the health clinics can provide them to anyone who needs them. But releasing these to the community, putting them in vending machines and in drugstores so that people can have easier access is truly important to increase the access in rural and remote areas. We have also tried areas in Africa where we use the community, particularly in churches, so we can deliver and distribute this type of products. It is important to work with the community and with the religious leaders so they have awareness of the importance of testing. Here in Brighton, we have a test where the American Express building has vending machines for ITS and HIV. So we can see the flexibility that this type of intervention has to increase the access. Now, not only self-detection, not only for HIV, but other types of ITS is increasing. This is not only through self-testing, but also through self-sampling, where they take the sample and take it to the lab so they can get a result. The advantage of this is that we can have other types of transmissions, transmittable diseases such as gonorrhea, chlamydia. So we have a kit where we have all of these instruments to create the sample. It is sent to the lab. The lab communicates to the health center and they communicate with the person so that they can begin with the treatment and the part of prevention, such as beginning PrEP, where they have negative results for HIV, but other positive results for other sexually transmitted diseases. This intervention is proven, but it depends on two major factors. First of all, the access, and then the cost. So, can the people actually find the products easily without any sort of barriers? And can they afford it? Or can they receive a subsidy so that they can receive them? Because there is a general interest in eliminating HIV because it is costly to the health system. We know there are lots of barriers to access to HIV prevention services. We have structural factors like the lack of policies to face this type of prevention services or prevention interventions that I just mentioned. Also, we have the cost factor. If we have enough structures so that we can implement this type of projects. Also, from the standpoint of socioeconomics, for the country, the region, or wherever you need to implement this project. Finally, we need to see the overall coverage of these services. Of course, we have cultural backgrounds that we all understand in our workplace regarding gender norms and the attitudes regarding HIV, discrimination, stigma. There are really specific factors to each network, such as family, friends, work, religion, which is really important, especially in Latin America, in Africa, and also the point of view of poverty and the way we increase the access to this type of intervention. We have individual factors and knowledge that people can gain access to, and the perception of risk that they can have, because that is one of the problems that we have. We have people that we know are part of key groups. But they are completely unaware they are exposed to HIV, even if they have had STDs that are not HIV. So they need to understand what's the benefit of knowing their HIV status. And that's why it is so important to have specific policies so they can have information distributed to everyone so that we can know and get effective treatment.
And of course, there are other barriers: cost, distance, availability of this type of products, as well as how are we going to make sure that not only people that can afford and pay for these products can get this type of products, but also available for all the people, even if they don't have resources to pay for that. That's the only way to make sure that everyone is going to have access to these uh, prevention methods. Now I'm going to speak about specific methods in my clinic in Brighton. Other examples on how to increase access to this type of products. I have been talking about options that people had traditionally to detect HIV and STDs, different than the PrEP. Traditionally, you have to go to a clinic for primary or secondary specialized services like the sex services that we have in our area, but we have tried to increase the supply, the offer of this type of options for patients. Currently, if they want, people can visit the webpage of the unit and they can ask for an HIV test or for an STD test that is going to be given to them. So we can offer this option for people that don't want to go to the clinic or don't have to go for a consultation. And they have the possibility to buy these products in vending machines. We have 9 of them in different parts of the city, libraries, university campus, or drugstores. And there is a possibility that by internet they can have an e-purchase, like a click a- and collect. They go to a specific drugstore to collect their kits without interacting with the staff. Or another option is that we work closely with organizations in the community where people can go directly to have this test or to buy the PrEP kit. I don't want to be repetitive, but I have to tell you that it's very important for people to know that this is going to be very beneficial for them. And this is r- something that requires marketing. If you want to sell something, if you want to raise awareness, we need to report this to the people. We need to let them know that this is very relevant for them. And this is one of the campaigns that we have organized in Brighton to convey how relevant is for people to conduct their self-test. So we need to have a very targeted marketing campaign so people can see that we are talking to them, and that is a targeted campaign. Online access is very important. This is just an example of the things that we can do with access online. There are 2 examples in the United Kingdom. Look at all the things that are available, and people can request them directly through the webpage, not only for HIV, but for also anti-conceptive conceptive methods and for the PrEP kit as well. We know that the evidence is there. Access to this type of measures, for example, to the internet, where people can take a sample and they can send it with the by the mail to the lab, and then the lab will be in touch with the patients. With the healthcare system is working. There is a problem regarding the returns of this type of material. This is one of the issues that we face, and we are working on that because oftentimes they don't uh, do the right test with enough blood, and tests cannot be done. But here we can see that there has been an specific increase in the sexual healthcare services and internet. There's no difference between the clinic and this type of services. And the same is happening because the average cost per sample and diagnosis have decreased significantly. And it's very important because we want to do more with less money. This is another example about the vending machines. This is an example of what the vending machines are um, selling specifically in Brighton. It's not only about the HIV test, but STD kits. The idea is to sell also PrEP and Doxy PEP products to prevent STDs. We know that vending machines have a large potential because they, depending on their location, they can be available 24/7. So they don't need a staff opposed to. But the most important thing is for tests to have a clear instructions, and usually they work successfully. If we compare in the United States, what is the cost of the test in a clinic? That it's around 53 sterling pounds. And if you do a self test, is around 9 sterling pounds. So you can see the difference in price and the impact of this type of measures. The fact that they can be located in different places is very convenient. This is just an example of the vending machines that we have in Brighton. And you can see that people can select and an oral test for STDs or for HIV, and they are distributed in different parts of the city. And this is the information that comes in the individual kits, where you can see clearly their results and what people need to do. And it is completely integrated with the internet system that we have. So people, if they cannot acquire through their internet, they can do it through their mobile phone. This is an assessment that we implemented some time ago. This is the potential for the vending machine, for the vending machines. They can focus on that specific target population that never conduct an HIV test or an STD test. As you can see, 28% did a test 1 year ago, or 29.7% have never had this type of test, and 22% haven't done a test ever. And this is our target group mainly. This is just to define acceptability, and in general terms, we have published several times the fact that acceptability, not only the intervention of vending machines, but the self tests are very well received. People like the fact that they have their privacy. And of course, there are other mechanical things that can happen, but the vending machine, it's quite a success. Some examples where you can see vending machines in Zambia for young people, in Japan, targeted for men having sex with men, and United Kingdom for general population, and in Australia for indigenous people in remote areas. There are other examples. The example of South Africa, a month ago, they launched this type of vending machines that are not only selling oral HIV tests, but other products for sexual health that are important for the population, for example, sanitary tampons and things like that. And this is another example from Canada. I'm pretty sure that my colleague is going to talk about that. It's including not only HIV tests, but also exchange of needles to prevent infection of hepatitis C. But let's talk about benefits and costs, because this is very important. There are many studies that have shown the cost benefit that implementing self test brings about. And there are many places in the world where this has happened. But it's important to focus on which is the benefit and the cost. That is very important when we are trying to look for funding this type of measures. We have to show them that there is a relevant cost benefit. They can save money and you can get very good results with this type of interventions and measures. So, for our countries, this is something that can be implemented. It should be implemented because we should give access to people that really need this type of strategies. I invite you to read this. The WHO recommendations for uh, HIV success keys. We are trying to eliminate some of the barriers to design policies, standards, so access can be very clear to this type of measures. We have to make sure that we can have a national plan, a very specific plan, so people can be aware of where this is going to be implemented and how patients are going to reach out to the healthcare systems in order to have treatment for HIV and they can abide by it and adhere to the treatment. And this is very relevant. I have to emphasize in this. We need to uh, empower the community. It's not just a matter of leaving the kids there because there is a lot of a stigma regarding HIV and STD, specifically in small rural areas. We have to be very careful. So, my recommendation is to speak with the leaders of the community to start having a conversation about what is the best way to implement this type of measures. And also, it's important to take into account the total cost of the service and not only talking about the cost benefit in the geographical site where they are located, because maybe the cost benefit is not going to be as clear. For example, in the United Kingdom, the cost benefit is changing because we have few HIV incidents of infection. So it's important to have a plan to monitor and to assess the programs regularly, specifically if you depend on assessment and evaluation to receive more funding. And I am showing you some of the examples in South America, how the press is considering this as a unique opportunity to root out HIV and AIDS. This can be useful. In Latin America and the Caribbean, we can see that some countries already have available the self-test for HIV, and there are some specific policies to handle this type of test. So I think that it's like a snowball that is just starting. What are the key messages before I give the floor to all the panelists so they can provide their examples on how they have implemented these measures in their country? HIV self-test to improve access to service of prevention is feasible and acceptable. This is clear, and we have to include and involve the communities because they know what are the barriers and what can be the facilitators for access. And it's very important to have access to the test, but it's as important as having access to services. If you don't have a clear access to treatment and if you don't give treatment to your patients, that wouldn't make sense. These are some awards and some of the people that we have worked with them. We are acknowledging them. Thank you so much. Thank you for this great introduction. It's important to involve the communities, and this is something that we are going to address in a moment. We are going to give the floor to the panelists so they can explain to us how they have implemented or these measures. Let's start with Mrs. Valerie Wilson, Director of the Foundation. Sorry for that, but we have some technical issues. healthcare professional. She is a leader and she has provided technical counseling to ministries of health, to laboratory, and to staff of private and public sectors in 23 countries. She has been the director of the Strengthening Labs funding by the European Union in the Caribbean Med Labs from the year 2007 2014, and she has working in the foundation of medical labs in the Caribbean. She has a master's degree in immunology and another in business administration with a lot of experience in public health laboratories, laboratory management, quality management, and strategy. She led the program to raise awareness between officers and entities in the Caribbean about quality standards for medical labs and their regulations. She led the design of a framework for a national policy in labs that was approved by the Ministry of Health in the 2014. She developed guidelines and strategic plans for lab services in different countries of of the Caribbean. A key role in the CARICOM for as a consultant by designing the public health CARPA, and she has the partnership with Pan Caribeña, HIV, CARICOM, PANCAP in the implementation of the laboratory of the Round 9 for strengthening national and regional networks of HIV and AIDS labs in the Caribbean 2011-2015 with a grant from the OECO for HIV intervention and TB during 2017-2019, and she has worked for vulnerable communities by the grant of BANCAP during 2019-2022. She has collaborated successfully with international agencies, including centers, food, think tanks, the Mikan Institute from Canada, and the European Union, and currently she is the member of the Regional Committee for Validation and the World Committee for Eliminating Mother-Child Infections. She has been part of experts in vitro from the United Nations. You have the floor.
Thank you very much for that extensive welcome, and thank you very much to the conveners of this forum for inviting me to participate. I'm very happy to share with you what we've been doing on HIV self-testing in the Caribbean, and I really thank Dr. Vera for starting us off with a great overview of what's actually happening globally with HIV self-testing. And he shared a similar kind of perspective in terms of the fact that HIV self-testing is really a very important part of prevention. And these combination prevention programs, which could be biomedical, in the case of HIV self-testing, condoms, lubricants, and so on. And then we have structural and behavioral aspects that also are very important for prevention. I'm not going to go into this slide in any detail. But the principles that HIV self-testing must uphold is that they must, uphold the WHO 5 C's of HIV testing, that they must involve that the person must give their own consent. And it may seem like someone doing self-testing must consent, but in fact, there can be coercion to do self-testing, but they must consent.
There's confidentiality really very important. The counseling side of things is not really handled in the HIV self-testing in the same way, but there's information that is provided. And of course, they must get correct test results and then be connected into the system if they require further help and treatment and care. And one of the important things is to address country and social and legal barriers to accessing the uptake of this test. In the Caribbean, there was a lot of reticence among governments and persons in the region about the self-test, as Dr. Vera mentioned. And so we know that it facilitates testing to those persons who may not access health services. And of course, it's important for those people who are initiating PrEP. What we did to try to convince, the adoption of HIV self-testing was that there was a pilot that was done in 11 of the Caribbean countries, and the countries are listed here: Barbados, Belize, Guyana, Suriname, Trinidad and Tobago, etc. And based on that pilot, which actually had, proved that there was 100% acceptance and concordance with the HIV in-country rapid test algorithms. The draft HIV policy for adopting HIV self-testing was developed with countries and inputs from both ministries of health and also the populations
Miss Wilson, perdón por interrumpirla. Parece que su audio está un poquito entrecortado. No sé si quiere apagar su...
in the process now of developing an e-health app that will support the HIV self-testing, so electronic application that will actually help those persons who are actually supporting or trying to do self-testing. And that is a collaboration between ourselves and the Caribbean vulnerable community. So again, working with the communities. I just want to give a couple of words on the HIV self-testing pilot. We really were evaluating the kids to see how they performed, to determine whether they were acceptable and feasible and how they actually performed in people's hands. So we could see if people were getting false positives or false negatives. And then, of course, that provided input to the policy. In the Caribbean, people were much happier with the idea of an oral self-test because they were very keen on finger stick. And so we created a lot of materials and so on that really were able to provide guidance to people in terms of how to do the test, etc. And we worked with the communities to identify persons who would actually use the test. And we did collect some data, as Dr. Vera mentioned in his presentation, about what participants thought of using the test. Most of them indicated, nearly 96% of them, almost 96% of them indicated they would definitely recommend HIV self-testing. Only 4% were a little unsure at the end of it. 60% of the respondents thought that the self-test would be accurate, and they indicated the preference for the oral versus the blood-based self-test. And their preferences included privacy, ease of use, the ability to test in their own time. So very similar to the results that Dr. Vera presented. Participants who took part in the pilot, who responded to the question about coercion, said they were not coerced to do the test, but they felt that it is possible that people could be coerced by their partners or their parents and siblings, etc. They definitely indicated their willingness to seek confirmation and care in either the public or the private sector if they had a reactive HIV self-test. And this was an important finding because this was a major concern for ministries of health in introducing these tests into communities, that persons would seek help and seek further assistance if they required it. And there were a few participants who had previously tested. This was a very interesting finding. There were some participants who had actually tested positively for HIV, but didn't believe that they were HIV positive. And then they ran the self-test themselves, and that convinced them that they were indeed, which was a very interesting finding. So the key success factors for us were working with the ministries and the organizations that serve the populations that we are trying to target in this. And the communication systems were essential. We had social media from the Ministry of Health and the organizations themselves that serve the key populations. The traditional media was even used by some of the persons going on the traditional media, like television interviews, etc. And of course, we had to take the tests where the clients were. There is now policy guidance for HIV self-testing in the Caribbean. And there's been a scale up in terms of the HIV self-testing. Both assisted and non-assisted testing is included in the policy guidance. And it is intended to be part of the national structure in terms of a facility for HIV testing. And the policy and guidance includes how you select the kits, whether you use an approved HIV self-test kit from the WHO listing of pre-qualified tests, that we actually, all the results to be confirmed before persons are referred for treatment. And then, of course, the kinds of support that people need for testing, whether assisted or unassisted, and the kinds of communication materials. And this is why we have the e-health app that is being developed now.
The distribution channels, of course, include those civil society organizations, the national AIDS programs, pharmacies, etc. We're looking at distribution channels and expanding those in the countries that have already started. And of course, ensuring that there are communication messages, not just for the persons using the test, but also for the healthcare providers, because it's important that healthcare providers themselves understand how the HIV self-test can really be helpful. Just a few words on the eHealth app. It actually includes sexual risk self-assessment, so persons can actually assess their own risk. And they actually also provide information in terms of the HIV self-test, when they have done it, what their result was, how they feel about it, etc. It gives information on how to conduct the self-test and about where they can actually access other kinds of testing as well, and treatment if necessary. And then it gives a directory to access peer counseling, treatment sites, etc. So the benefits of that health app are really that it will allow us to collect data. The clients themselves will get a lot of information, a lot of support, knowing how to do the self-test, etc., and other information and their own risk assessment. And of course, be able to access persons to support them. But for the national program, there's also a real important part there in terms of collecting data on the results of self-tests and what's actually happening there in terms of who's doing it, what are the age groups, etc., etc. These are just some of the indicators that we're trying to monitor, looking at the eHealth app for if persons have sent in questions, how many tests we actually distribute, the number of persons who report that they've used the test, and those who are reactive and actually go into care. So some of the indicators. So the current situation now is the Ministry of Health in all the 11 pilot countries have received the results of the pilot and the draft HIV self-test policy. 4 countries now have introduced the HIV self-test policies and are providing HIV self-tests as an option for clients. And the eHealth app, as I said, is in development, and we're working with the 8 countries to really introduce their policies and roll out their HIV self-test. So I thank you, and I end there.
Gracias, Mrs. Wilson. Muy interesante las políticas de difusión que han implementado, además de manera regional.
Thank you very much. It's been interesting what you've done on the regional level. That's why we appreciate so much your sharing your experience. Now we will have Dr. Sean Rourke, who is part of Rich Nexus, and he's a clinical neuropsychologist talking about the implications of HIV on the neuroconductual aspects. They are taking an outlook on science and education to have a deeper impact on the front line of the clinical systems for those who live with HIV/AIDS, and they reduce the risk of contagion. He works with communities and they work on investigation for greater action to reach those who are not diagnosed or not receiving treatment. They are looking to combat the HIV and eradicate HIV in Canada. The floor is yours, Doctor.
Thank you so much for the invitation, and it's wonderful to be part of with Jamie and Valerie and others. Just gonna pull up my slides here. Just to make sure I pull up the right ones. Just one sec here. So can you see my screen? Yes, perfect. So in the next sort of 5-7 minutes, again, pleasure to be part of such a amazing group and share with you where we are in Canada. Really going to show you more about sort of 3 ways that we're reaching people who are undiagnosed. 1 out of 10 people who are living with HIV in Canada don't know it, and really working to find the right ways to reach people where they are and help them get tested and connected to care. So, to do this, we had to get an HIV self-test approved, and we did that back in 2020. We were one of the last G7 countries to do that. And so we got the INSTI HIV self-test approved. We also have a whole pathway of other tests. We have HIV and syphilis point of care and other self-tests that are in the pipeline that we can chat about. But once we got that, I'm going to share with you our I'm Ready program that's reaching people using an app. We also have a program that we're leading with the government of Canada, the Public Health Agency of Canada, to distribute through community-based agencies. And then, like Jamie, we have these smart vending machines. We call them our health box. And I'll show you just 3 different ways that we're trying to reach people and meet them where they are. So first, we have an app. You can download it on iPhone or Android. It allows people to order a test kit and have it delivered right to where they are anywhere in Canada. Or if they're not comfortable with that, to pick it up at 80 to 90 locations across Canada. In addition to that, people can, all the care pathways for how to get tested and confirmatory care that they need are built in the app, so you can do it yourself. And built into this, if a person's interested and needs support before, during, or after they test, they can talk to a peer health navigator online. So they can book an appointment and talk to somebody in English or French and get support to help with the testing and help with the linkage to care. So we've reached almost 15,000 people using the app. It's worked really well. People can order 3 tests. We encourage people to give them to others. So for secondary distribution, we know that works. It's anonymous and confidential. As part of our program up until the end of 2023, it was a research program, and now it's not. But we were collecting data as part of our research program and really kind of understand, you know, more about that whole cascade and how people are getting access. So here you can see here about 6 out of 10 people will be comfortable having it delivered. 40% pick it up. We're reaching principally younger people using an app-based approach. All 37% are first-time testers, but we're really reaching across various key populations. And as you can see in the map from Canada, reaching people who may not otherwise get tested if you didn't have an app, and they can have it delivered right to where they are. Because in Canada is really a vast country, and it really helps to have that option of delivering. Here again, too, is just our first-time testers. And just to show you on the bottom left here, not only is 38%, but another third haven't tested for more than a year. So 70% of people aren't getting tested as often as they should be, or at all. And that's really very concerning. Our second program is working with the government, where we've distributed almost, now the number's up to almost 250,000 kits. Again, it's the INSTI. And we've partnered with over 400 agencies across the country and working to help distribute sort of one-on-one with community agencies, and also have testing events. This is across Canada, British Columbia, Alberta, all the way to Northwest Territories on the right. And the different kinds of agencies that we're working with to bring the testing into those agencies, and for them to be conduits where people can come and connect with someone and get access to testing, either through a health center, a community-based organization, a shelter, a pharmacy, and so on. So lots of options for people to get connected. And then here's who we're reaching. And if you think about sort of key populations, you can see in blue here, you know, up on the left, 59% are first-time testers, African, Caribbean, and Black folks, 57, and so on. So clearly we're reaching, and we have data in real time to understand who we're reaching and how to design our social activation and our supports to get advertisement for this program. Again, we're working also with a company called Esri Canada that helps us do GIS mapping. And this is a dashboard that is very dynamic. When you scroll in and out, you can see sort of where people are. On the right here is where the kits are being distributed, but then you can actually look at first-time testers by key population and really think about where it's working and where it's not, and how to develop better strategies. A lot of that has been supported online through im.health, that people can just, you know, again, go online, figure out where those options are. And we have some interesting work going on with our key populations to, you know, to make sure that people can see themselves in in the communities that they're part of, and how to think about the advertisement around that. We had this really interesting program with Starbucks that we launched last year, having Starbucks posters up on in on billboards in the stores, and people could click a QR code, come right to a web page to get a kit and get support. So really think about how do you break down barriers. And then lastly, our health box. So these are 1,500-pound vending machines that are really state of the art, and have really a low barrier access, not only for self-testing, but for other kinds of things that people need to take care of their health. Has service maps in there so people can know where to go, and it's also is being currently evaluated. So in addition to self-testing kits, there's uh, new needles, crack kits, naloxone, even smudge kits, where we have a very significant proportion of people who want to reach who are from Indigenous First Nations communities, and having smudge kits has been really important. But you think of all the things, then other things that we naturally take for granted, we want those to be in the machines, and each agency decides what goes in it. Here's some examples in real time. This is out in New Brunswick, where we launched last year. Outside of a community-based agency on the left, on the top right here, this is a United Church. It's right inside this door here. This is inside of a pharmacy, with actually a methadone program, and outside, right beside a health center in a First Nations community in Woodstock. So this is a program too that Staples Canada, and a program called Even the Odds that's funding the whole implementation. We're really excited to have these private partners to support us, and we're launching 100 machines across Canada. You can see here machines are at various stages, and it really works. People find it very acceptable, low barrier, and our work as we continue is to think about community-based agencies and how do you get the funding that's needed to keep these programs running. At the end of the day, it's implement, and execute, and really make sure that the connections to care are there, and how to be really novel about building and supporting models of care to reach those who are undiagnosed. So with that, I'll turn it back to the organizers. Thanks for the opportunity to present on some of the work we're doing in Canada.
Thank you very much, Dr. Sean. It has been a really enriching intervention on what you've been doing in Canada. To continue with this first intervention stage, now I will introduce Dr. Leonardo Chanqueo of the Ministry of Health in Chile. He's an internist and infectologist, and he is renowned for his work in public health and infection diseases in Chile. He has developed key works in several institutions of healthcare in the country. He is a former president of Infectologist Society in Chile. He is committed with health and prevention of infectious diseases in the community. His knowledge has been key to the healthcare of Chile. Dr. Shanqueo is currently the head of the Department of the Prevention Unit of HIV/AIDS and STDs in the prevention of diseases in the Ministry of Health in Chile. He leads initiatives that are key for the development of HIV prevention and contributes to increase the life quality of the Chilean people. Thank you very much. Thank you very much, everyone, for inviting me to this conference and to the committee. Thank you for this presentation. Can you see this in full screen? Yes. We will tell you about this program so you can see how we can implement in different strategies in Chile. Our objective to implement this self-test is to increase access. This is just another part of the testing that we need to do on people in our country through the use of self-testing to contribute to the timely diagnosis with full respect to the autonomy of the persons. This is a strategy that began a while ago. We consider three phases. First of all, the regulation, then the planning, and then the implementation. Regarding regulation, in 2019 we began with the regulatory document for the self-test. It takes into account a QR within the box. It leads also to a web page that we deployed on our country. We need, we also created awareness on the doctors so that they know what to do if someone arrives to the clinic with a test that's reactive or non-reactive, and the planning stage. Initially, we did an OPS survey, and we work with NGOs to see the testing that the people preferred and where they preferred to have the self-testing. That's what we did as a planning. We did a centralized purchase as a health ministry. So we could distribute to the centers that we thought were best suited. In Chile, this is a public health measure, so it is free for everyone, regardless of the health insurance that the person uses. During the planning, we also created a web page during which people can access. There's also a Q&A, and they have a self-report if they want to be contacted or not. We believe it is important to link people. We also have an implementation phase. As such, we implemented it on May last year, and within this government, we tried to split things on a decentralized basis. So we divided on the regions of the country. We started on Iquique, then we went southern to the Magallanes region, and then we finished the implementation for the pilot with four regions on the on Valparaíso, that is on the central part of Chile. As of December 1st, we implemented the national strategy for all regions of the country. So that, as you know, on December 1st, we commemorate the AIDS Day. That's why we implemented this on the Awareness Day of AIDS. Here we have the self-test and how we created our device. Here it has a QR code where you can see this screen. We have the voluntary report. I can access this through minsal.cl, and here we can create the voluntary report. This is an anonymous survey. We have data that's interesting, and we see the accessibility survey. If it is easy, if it is clear, if the interpretation of the result is clear as well. Now, regarding regulation, it is important to note that to see how the person accesses the healthcare system, if it is clear to them or not. This is a free tool, regardless of the insurance. And we did lots of training for those who deliver the kits because we understand it is important to have a pre-test guiding so that people can actually know how to act facing a person, how to explain to them. It is also important to see this window of opportunity because sometimes people are really anxious because the test can be really fast and they think it is not as useful. So that's why it is important to tell people how often they can do the test. That's why we have phone hotlines that are available 24/7 within our industry standards. We have different funds that help people do the self-testing and do a follow-up. Currently, self-test is available countrywide. We have the website. We have a link that takes us to the regional level, and we are working on a territorial basis. We are distributing the self-test across the country. We have healthcare clinics, we have infection disease clinics, and PrEP centers, as well as attention for those with STDs. And the foundation is the civil society. We are using them with the distribution of the self-testing units. We also have diversity municipality workshops, and we also work with cross sectors. We work with other ministries apart from the health ministry, with the women's ministry, with the social welfare ministry. We are working with the NGOs. They have really helped us a lot, and they are valuable to this strategy. We also work in fests and fairs. We had the Lollapalooza Fest. Here we delivered 4,700 self-test kits. It is a strategy that was really well evaluated by concert goers. We also go to carnivals like the one in the north, so that people can access within their territory to this type of tests. This is my presentation. Thank you very much for listening to me. Thank you very much. It was a very concise presentation. It is interesting to see the workflow for patients. Finally, to ending this stage of initial presentation, we will have Dr. Ricardo Lupe Núñez, who's the coordinator of sexuality and reproductive rights for the Ministry of Health of Colombia. He's a physician for the Pontificia Universidad Javeriana. He worked also studying in Madrid. He's a specialist in pedagogy, and a specialist in bioethics by the Pontificia Universidad Javeriana. He has a master on HIV/AIDS infection. He also is part of the network of hospitality. He is also a teacher on reproductive health in the Del Bosque University. He is currently coordinator of the sexuality, sexual and reproductive rights on the promotion and prevention of the Ministry of Health in Colombia. Thank you very much, Doctor. Thank you very much, Dr. Perez. And thank you very much, Dr. Alvaro Velarca, for this invitation that you brought to us for CISS in Mexico. It is a pleasure for me to have you, and I greet everyone within this panel and our audience. We will do a short summary of what we've done on the country so that we can control these epidemics. In our country, the number of total cases is around 180,000. This is the number of people that we have. And if we go down to those who are eligible, we see that the percentage oftentimes is okay. So as long as we diagnose people, the access to the healthcare system is guaranteed through the health insurance system. But definitely, the gap is within the diagnosis. Therefore, the diagnosis is front and center of the strategies to prevent, where the STD control, the indetectable viral burden, remembering that indetectable equals intransmissible, and to provide PrEP to those in risk through prophylaxis. The programmed goal, regardless of the means, if it is institutional or if it is a self-test for the country, is that for 2026, we are aiming that at least 36% of those who live with HIV is diagnosed early in the infection according to the CDC clinical classification of 2014, where this is less than 6 months. And the first stage is with a CD4 greater than 500. For 2019, the baseline is 80.7%, and we are doubling efforts to reach our goals. This self-test is not isolated. In 2021, we strongly worked with analyzing the evidence to issue the recommendations, not only for the self-testing, but also for PrEP, also prophylaxis post-exposure, which is a recommendation that's been doing for years now, but we reinforce it, and also the focus to treat as soon as possible everyone who lives with the virus. Regarding the self-test, the diagnosis recommendation is all adults, teenagers, and pregnant women with HIV that is being done according to the current algorithm. Of course, we need to do campaigns to raise awareness and to do the self-testing. According to the clinical recommendation, the evidence tells us, firstly, is something that Dr. Jaime Vera just mentioned in terms of precision. The precision of the self-test has been both in sensitivity and specificity greater to 80%. But this, in regards with acceptance, we see that this increases the ease of access, and the people who do this is greater to the standard of care. This talks about their clinical usefulness. Evidence also tells us about how important it is to distribute this type of kits to key populations facing discrimination, which is something that has been talked about. Also, for scenarios that are hard of access, and in COVID-19, we see that the harder it is to access healthcare, self-testing can be an alternative to a solution. There's minimum psychological or physical damage, and this is obtained when you work with the alternative, which is the institutions. People look to have services to prevention or attention, and that is a cost-effective strategy. All of this is information that we got from the review and with the technology that we have with evidence-based medicine. Now, talking about distribution in our country, collective interventions use key population projects or international cooperation projects such as the World Fund, so that we can work in distributing this type of self-kits. Also, out-of-pocket expenses in pharmacies, vending machines. This vending machine strategy is something that we are still lagging, especially in comparison with Canada. Or we can buy through internet. Regarding the attention system for the individual, this is financed to the unity of payment through gathering, which is the risk premium that all the insurance companies receive per person so that they can provide all the healthcare attention. Here we foresee that we can deliver kits for the partners of those who had a recent diagnosis, also sexual and reproductive services for STDs, abortions, gender violence cases, teenager-friendly services, or services where anticonceptives are being provided, as well as PrEP programs. So it is not everyone within the system, but those who are receiving services in selected locations where the persons interested go. Also, possible sites include workplaces and others. And what are the challenges to the implementation? In certain subgroups, there is no benefit for self-test. Just as Dr. Vera mentioned, the young ones seem to trust on the result. There is no larger interest, especially those who are between 15 and 24, those who work as prostitutes or in prostitution context. That is to say that they do the test, but they don't trust so much the test so that they can go to the health service. Thus, we need to generate guidelines, and we are missing the inclusion of a legal framework to these selected distribution points. We need to raise more awareness in the community, and also community distribution is something I just mentioned. Paradigm modification, we are working with campaigns to promote this technology, and this can help a lot. Financing, we need to see that self-testing is a more costly technology than quick tests that are done on communities or even those who are done on the institutions. Also, a big challenge is to have the proper information systems so we can have an insight on what Chile presents on QR codes and how people can do this self-reporting for infections. Also, an important part of this is having those interested in selling and distributing this self-test in drugstores. And we had also the sanitary registry for these over-the-counter tests. So in sum, this is what I have for you. Thank you very much again to the CISS during this Social Security Week. And thank you for the invitation, and I am all yours in case you have any comment or question. Thank you very much.
We have heard very interesting presentations. We are running out of time, but I would like to exchange some of the ideas and the questions that have emerged from your presentations. Maybe we can elaborate on these subject matters. So now I would like to ask 3 of the 5 questions that we had planned for you. If you want to answer the questions, raise your hand in the Zoom so I can give you the floor. Please take 2 minutes to answer the questions so we can have an ongoing session. The first question. In the closing of Dr. Luque's presentation, what were the legal considerations related with the sanitary system for the implementation of self-test for HIV. Dr. Leonardo has the floor.
Le doy la palabra, adelante.
You have the floor. In the year 2019, we started with a regulation because it's very important to have a regulatory framework. So we need to have security. It was a president's decision. It has legal force and it has been approved by the regulatory agencies. All these devices have to have a certainty or accuracy of 99%, as well as availability. In our National Regulatory Center for Laboratories, that is part of our public health center, set forth the regulation for this type of devices. So they have a document review about the indications, the performance, and the performance of the test is very high. So this should be a device for in vitro use. It's very important to have instructions in Spanish. If it's a foreign product, it has to be translated into Spanish. We made a central procurement because we buy the blood self-testing. That was the most affordable one for us. And in my slide, I presented to you the regulatory requirements. They need to have a QR code to have access to the web page of the Ministry of Health. So with that, we make sure that the educational material is going to be available for all the people that have access to the test. This device has a warning. This device is not a diagnosis. It's important to remember that these kits are not for diagnosis purpose because they need to have a complementary test. So that was the main part of the implementation. Thank you so much. The process was very interesting in Chile. Mrs. Wilson raised her hand. You have the floor.
Thank you. And I just wanted to flag that for us in the Caribbean, we didn't actually go the route of trying to put a law in place, but what we have is policy. So it still comes with the government's authority in terms of having a policy that actually adopts HIV self-testing. And the test that we have actually verified for use and is being used is the oral test because people indicated a preference for the oral test, and there was only one oral test at the time that we actually did the introduction that was pre-qualified by WHO. But within the policy, it states that the tests that are used must be pre-qualified by WHO, and then there is a process of ensuring that it works within our environment before it is actually adopted and approved by the Ministry of Health. So there is an approval process for introducing different kinds of self-tests. Thank you.
Muchas gracias, Mrs. Wilson. Y más considerando
Thank you so much, Mrs. Wilson. In your case, it was a whole region where you implemented the test. That was very interesting. Thank you so much. Thank you, Dr. Fedes. I would like to build on what Dr. Wilson mentioned, because before the implementation, we enable a policy for healthcare institutions. It's mandatory that when you enable a service, you need to have national guidelines that are mandatory. So the strategy was to elaborate a clinical guideline, and we make some recommendations. We analyze all the budget so it can be included within the budget. Once we did all these processes according to the recommendation. Healthcare services are authorized to fund and to supply the self-test. And afterwards, we have distribution centers, reporting centers, where we are working now. And currently, there is a bill of law that somehow authorizes the content for epidemic control. And of course, they are mentioning self-test.
Muchas gracias, doctor. Creo que muy
Thank you
interesante
so much, doctor. That project, that bill of law is very interesting in order to support the self-test systems. I see no more raised hands, so I am going to continue with the next question. Dr. Vera mentioned this during his presentation. How the self-test strategies have been implemented in the community so they can be used successfully.
No sé si algún panelista quisiera hacer uso de la voz.
Does anyone would like to answer this question?
Ok, veo la mano levantada.
This is one of the main challenges that we face. There are some pilot programs where more than 14 self-tests have been distributed in the communities, in the community centers. The World Bank funded this project. However, there is a lack of an appropriate information system like the one that Dr. Chanquero presented to us. Sorry, the doctor in Chile. So it didn't give us good results. So we can say that there were return rates or not. Of course, we have implemented quick tests in community environments. Different healthcare providers can give this test. General doctors, nurses, dentists can give this test. So with that mechanism, we operate this type of strategies. But the main issue is budget. There is a possibility to deliver the test at a community level, but it's necessary to be done through specific programs. And we don't want to be very involved till we don't fine tune all the information
Ok, adelante, doctor Vera.
approach or strategy. Thank you. Thank you so much. Something that is fundamental is being able to involve the community. Is it better now? Yes. It's very important to understand first the target population where you are going to offer, who you are going to offer this type of test, and to involve them because every population is very different. In the United Kingdom, the pandemic is men having sex with men, but now this is changing because we would like to, we would like for heterosexual people coming from other countries to have access to tests. This is changing constantly. Depending on how the pandemic is changing, we need to be flexible. So we don't implement the self-test the same way as we did in the year 2015 when we started with this strategy in the United Kingdom. But so it's very important to understand what is the target population that I would like to outreach with this measure and how I would like to work with the community because they know the vast majority of the barriers is with the healthcare staff because they think that in the communities they are not going to have the test or structural barriers. It's very important to know the community. That's key. So it's changing constantly as time goes by. Thank you so much, doctor. Dr. Leonardo raised his hand. You have the floor. It's kind of the same. I work with the civil organization and with different NGOs. So it's very important to work with them. This is an ongoing work because everything is changing. We have a long and an ongoing changing territory. So we have worked with every region with an outreach approach so we can work with NGOs, with the civil society, and with indigenous people. We have developed strategies for indigenous people where they can have available this type of devices according to their costumes. And we also did a consulting work with the OPS to measure the level of acceptance. We did this together with the civil society. This is an ongoing work. We still work on that because it's important to involve the community and to work together with them. Thank you so much, Leonardo, Dr. Leonardo. Dr. Shan, you have the floor. You raised your hand.
Thanks so much. Just to expand a bit on the other panelists too, I think what we've found really helpful is to be able to find a way to monitor and evaluate the implementation at the same time, so you have real-time data. And so the example that I gave you, so in our app, it's automatic when people get kits and fill out some questions, it goes right into our data and we can see what's happening every day. But with our frontline partners and our community-based agencies, like to be able to reach all of these different key populations, again, made it part of the conversation. But when people are ordering kits, they use their phone or their laptop or just to enter a few pieces of information. Again, comes right into our data, so that we have these QI indicators for who we're reaching and the age. And we've also expanded it to include a lot of different ways for people to self-identify in terms of gender and sexual orientation. And we found that it's been extremely useful to sort of understand who you're reaching and who you're not, and how to then think about your strategies, the social marketing and activation strategies and outreach to know. I mean, we're just on the beginning of this journey, but it's really interesting to think about how across countries, if we started to do that, we could actually there's these tools that are just available now, and to monitor one country, it'd be cool to be able to sort of do this across countries would be something that would be really interesting too. But I just want to flag, like, the data in real time has been incredibly helpful to us, and there's technology is so user friendly now. It really, you can build these in and can really help. So just kind of added a piece to, again, the agencies then get their data and can say, reaching this many people, and these are the people that we're reaching, and here's and to help them really have what they need to influence more efforts.
Muchísimas gracias, Dr. Shan. De hecho,
thank you so much, Dr. Shan. We are discussing that your presentations have been very interesting. Leonardo, you have the floor. Well, I had a question for Dr. Rowe. What is the percentage of people that are responding to your studies, or that can respond the whole questionnaire that you have in your website? Because I want to tell you that here we have an online and voluntary report, and within the regulatory framework, they need to receive a number so they can have access to the web page in a confidential manner. But our report or the feedback that we receive is not very high. So I want to know, what is the feedback percentage that you receive from the users that have access to your app?
Yeah, great question. So when we ran it as a research program, it's no longer that. In order for people to get access, they had to complete, a questionnaire. And so they couldn't order their kits until they did that. So the rate's high, but they could skip over questions if they didn't feel comfortable in responding to one or felt it was too many. By and large, the high rates of response. Now, having said that, in our app, we ask for there's push notifications, for follow-up things, and the rates of success go down considerably. But also the reason we have push notifications is to, when you get your person they decide to test and get the results, in order to put them on the right pathway for prevention, if they're negative, and resources for PrEP, they need to sort of come back in the app and say, I tested negative, and then they get this information that they can then use. Similarly with positive, what that pathway looks like. So the initial piece works. It goes down considerably after. In our program with frontline agencies, about 85 to 90% of people are comfortable, answering, 8 to 9, 10 questions. So it depends on how you do it. But you have a couple of minutes sometimes, and that's it. And it seems to have worked. But obviously not everyone fills it out, and people can obviously skip things, and you want to always have those options. But I think what's also interesting with identity now and intersectionality is that it's been remarkable how many people have, will check off things about, different gender and sexual orientation, which has been very helpful to help us understand more about who we're reaching that has, and who we're not. So hopefully that helps a bit.
Muchas gracias, Dr. Sean.
Thank you so much, Dr. Sean. Before giving the floor to Dr. Vera, that was going to be the next question. If all the panelists would like to talk about what is the follow-up for the people that are getting an HIV test. You have the floor, Dr. Vera? I can see you on the camera, doctor. I was trying to explain this question because in the United Kingdom, we have two ways different to do it. One is the internet service. In order for you to get the self-test or the kits for STDs, is necessary to complete the questionnaire because their results have to be received by mail. However, with the vending machine, we have a lot of barriers. The more information that you ask for, more confidentiality problems people can have, and there are more barriers. So we need to have a balance. So that's why we ask the community, what are the type of questions that you could answer? How many questions? And sometimes it works, so you can have the balance to collect the information that you need. There is a barrier to have access to this type of service. But as Dr. Shan mentioned, the digital part is very important. The application is very important because with this type of intervention, you can receive a lot of analytical information and you can collect useful information to modify and to adapt quickly the service. Thank you so much, Dr. Vera. Any other of the members of the panel would like to elaborate on how, what type of follow-up you give to an HIV, a person that has received an HIV test? You have the floor, yes.
Thanks. Yeah, so we've, again, thought about this from the standpoint of just providing a lot of options for people. So whether it's, on an app or in front, making sure we spend a lot of time in Canada, we have, 10 provinces and 3 territories. So we had to have all the care pathways mapped out with all of the resources. and just you find ways of making sure that at every opportunity you let people know, well, when you're going to test, make sure you have all this information available to you so you can decide, when you do test, get your result, that you have prepared sort of what the next steps are, and whether you need to talk to somebody or what kind of follow-up you need. So really thinking about that digitally, and then available sometimes, so in our health box, putting a QR code in on a postcard so people can actually download the information. Or if they can't do it there, go somewhere else. So it's always doing that. While I have the floor, I'll just say another comment though about having data in real time, and what in terms of government, what governments want to have for decision making. And we're in a current situation right now where our government has funded our program, our national program, for 15 months, and we have data in real time, as I mentioned and I showed you. And we also have impact stories on individuals, and what that they're getting tested and diagnosed and getting connected to care. And so those real life stories have been very important. Having said that, even when policymakers wants data and stories, it still can be a struggle. I'm in the media a lot recently because to push them to say, what, we've done this and it's been effective, continue to fund it. So that's a balancing act of constantly putting pressure on to say, when things are working, keep them going. So just a little bit of editorial there on just, once you get it going, you want to keep it going and keep it scaling, but you run into these roadblocks where governments, are strapped with resources, and you have to keep on finding that way to build the case. So just a little bit more on that side.
Thank you so much for your comments, Dr. Shin. And you have the floor. This is a balancing act. We want people to have access, but we have barriers for that. But our target is access. The access has to be easy, fast, without asking for so many data. That's why we don't condition the voluntary report and the provision of information as an exchange to give them the kit. In Canada, you answer the question and you receive the kit. For us, it's different. We expect to receive the voluntary report. We emphasize that training the staff is very important, whether it's healthcare staff, NGOs, or civil society that are going to be giving this device, because we understand that it's very important for people to be trained. In the video, we tell them that they need to abide all the instructions in order to have a good result. And we have a 24/7 hotline. We have hotlines available for receiving feedback. And another aspect is that we have a voluntary feedback. The rate is not very high, but people like the self-test, and people would like to be in touch directly with us so we can refer them to a healthcare center. That's the experience that we have had. Thank you so much, Dr. Leonard. We are about to wrap up because we are running out of time. The last question before giving the floor to our colleague from COFEPRIS. In your opinion, what are the next steps to have access to prevention, detention, and treatment for people living with HIV? Would you like to have the floor? Dr. Luque, you have the floor. The next steps are to keep on working in a comprehensive manner. This strategy is not an isolated one. It's necessary to be linked to other prevention strategies. We need training, education, in order to reduce stigma, discrimination. This has to be considered as a structural measure, and we need to provide access to the community, and we have to link this to prophylaxis services as well. And we have to consider all the available technologies in order to minimize the impact of this epidemic in our country. Because as Dr. Olvera mentioned, in our countries, despite the fact incidence rates are decreasing in other parts of the country, in Latin America, that's not the case. However, I think that it's of the utmost important to fine tune the information systems, being able to have traceability. Resources in healthcare services in our countries are scarce, are low. So we don't want to deliver inputs that are not going to be useful for their purpose. Specifically, when we talk about the self test, I think that it's necessary to strengthen uh, good strategies for information, communication, and implementation, not for this self test as it is, because the self test is just one of the ways to reach diagnosis. But in parallel, the exit door should be having fine-tuned information tools to know what are the return rates with more accuracy.
Thank you, Dr. Vera. I think it is important to link the healthcare system with the other prevention system because although self-testing is important, only self-testing is not going to get rid of HIV transmission. We need to link this with the healthcare system so that if they have a positive test, they can go to the healthcare system to get a confirmation test and if to take any prep if they are at any risk or if they are positive, they can receive treatment as soon as possible. It is not possible to do it if there is not link. And in the UK, we have had all the testing, but what actually impacts HIV is the access to PrEP and the integration to the testing access. Also, recently, the incorporation of PAW tests for HIV in the emergency systems in places where there is a high prevalence of HIV, where they are pretty much tested by default on HIV, and that's having an impact. So, do we have several levels on prevention to get rid of HIV? Self testing is a beginning, and it is important to get the community involved. Thank you very much, Dr. Ver. Ms. Goldson, the floor is yours.
Thank you. And I just wanted to comment, of course, Dr. Vera and Dr. Luque have already put it into a very good frame, that in fact it is really key. Self-testing alone is not enough. And one of the challenges we have had within the Caribbean region is, in fact, the rollout of PrEP and ensuring that PrEP is actually available and able to be accessed by those who need it. And I think that one of the key things for us, given the fact that we are seeing within the region up to sometimes 30% of the people who are actually diagnosed are actually late stage. So they're coming in with CD4 counts less than 200, and we need to create a more welcoming environment and to work with those organizations
that work with those populations to ensure that we can bring them into the fold and actually identify those persons who really need to either have PrEP or to be on treatment because they are indeed HIV positive. So I think this is something that you really need to work towards. It's a very important part, and it has to be something that we actually focus on for this region and for the world. And I think to ensure that the context is not just HIV self-testing, but we have to have a very holistic approach to the whole thing. Thank you.
Muchas gracias, Miss Wilson. Adelante, doctor Vera.
Thank you very much, Ms. Wilson. Dr. Bear, I do believe self-testing is really important. It is the first step where people do not have contact with the healthcare system and they are afraid of stigma and they are empowered to self-test. So it works to do the self-testing. And as the next way, it has worked. I believe it stimulates others to be able to try this type of services as an intervention. So I believe self-testing has a high value to reduce social stigma related to testing. And I believe this can be an entry point to other prevention services. Thank you very much, Dr. Vera. That's the last of the questions that we have planned for this panel. And now I will have the industrial chemical expert, Nayeli, who studied in the National Polytechnic Institute, and she has several years of experience as part of the risk evaluation for medical devices. She worked also in regulating and on the private industry, and she is currently part of the records of medical devices class 2. She is working on resolution of equipment. She has worked also and taken a seminar on Sigma 6 Lean, as well as a risk evaluation for sanitary products by the National University of Mexico. The floor is yours, Ms. Nayeli. Hello, everyone. Good day. We are just about to wrap up all of this. It has been truly important information because we share a common goal, which is making all HIV detection reach the population across sectors. Currently, in COFEPRIS, we work for the test of HIV tests. According to our laws for medical devices and the proper statement, on the version 4.0, this is a class 2 diagnosis agent. After being updated on 2023, now we classify this device as a class 3 device due to the level of risk that the test entails. COFEPRIS emphasizes 3 types of tests: antibodies, anti-antigen antibody test, and the nucleic acid, or NAC. Currently, antibody tests are the most prevalent because they are easier to access. We only need to detect the antibody that HIV produces. We have self-tests, we have quick tests that are feasible as they can be done on blood or oral fluid or urine. In oral fluid, it would be through the mouth cells to detect antibodies, and through urine, it would be also through the antibodies that can be detected. We need to emphasize that this type of tests are also being monitored by the FDA. They work with self-testing and they are only recognized antibodies. That's why we are actually pushing for that type of testing. Currently, we have seen cases where we received the dossier and they work with oral fluids, with finger pricks. And they are quick tests that are accessible to the population. We have other types of tests that are antigen antibody that are based both on the detection of the antigen that the HIV emits and the antibody. We also have the record of quick tests that work on blood, and this limits the ease of access to the general population. Also, the prices can increase in comparison to antibodies. It can be done on a clinical lab as well with home tests. We also have nucleic acid tests. Or NAC, according to the documentation that we receive, it is an exact test. However, we need to extract the blood through the vein. So the population, due to different constraints such as money or quickness, they can not access to these type of tests. In order for COFEPRIS to approve this type of tests I just mentioned, we do the performance tests. We try to see they don't have cross reactivity. The specificity and sensitivity are truly important for the detection test that we are currently performing. We aim to more than 99% accuracy so that the population can have an efficient test as well as a safe test that makes them feel that when they do the test, they are sure about the result. It is also worth mentioning that this type of tests need to be raising the awareness of. We need to see the time frame between the point of contact and the testing, because this type of testing, for instance, they are not all done after the contact, immediately after. They need to take some time for the antibody to be produced, to have certain characteristics present. So I believe the population is still not aware of the risks, so that they know they have a given window of opportunity to do the test without having false positives or false negatives. Another important point in Mexico, through the Mexican official norm of 2023 that is issued on the official gazette on June 2023 regarding the prevention and control of the HIV. Here we introduce self-testing as a term, both normal and assisted, where the user is trained so that they can do the tests accordingly. We have seen that in several tests, both the paperwork and the clinical tests that we do, we see they have the proper efficiency and detection of HIV. Unfortunately, sometimes people do not know how to apply or use the test, and this leads to user rendering the results invalid with false negatives or false positives. Currently, the guidelines state that we need to have quality controls that are available to everyone. That's the main goal in this Office of Regulation, to have more safety in the test, more reliability in the test, so that they adhere to the guidelines that we currently have to make it accessible to the population. Another point that's worth mentioning is that the health ministry needs to provide training for the test process so that people can actually handle and use the test. We have cases of self-tests. We have one that is done through a swab or oral fluid. In this case, certain conditions must be met with to do it in the right way to have the proper results. It has a solution when you introduce the swab, but if you contaminate, pollute it in some way, the results are rendered invalid for the test. Therefore, as a commission and as the regulator body for this type of test, we need to have the commitment to have tests that meet the characteristics that go according to the guidelines and norms for an effective performance and a safe performance as well. Self-test is within the reach of the population. That is important. Sometimes people avoided doing the test due to fear to going to a clinic, to facing discrimination within this type of testing processes. But this type of kits are pretty cheap and people can actually do the testing and they can receive an early diagnosis so that they can receive a follow-up in case of having the disease. It is also worth mentioning that every test will have an amount of doubt, especially self-tests. Of course, we verify that the tests we receive have a pretty much 100% sensibility and sensitivity, but some may fail due to the poor employment of the test or other factors. So it is important to raise awareness in the population so that they can use the test properly, both for antibody and antigen. They are more exact because they are done through blood and they provide more antibodies. We improve detection with HIV virus. It is important that everyone as a population is aware of this type of test, the test that can be performed to detect HIV, and the time span that they need to wait to do the test so that they are certain that they have or they do not have the virus. We also need to see quick tests. They are safe and they are faster in detecting the presence of the virus or the lack thereof. Here, it depends on the type of population or the type of person. We currently have this type of test available on the market as long as the needs are met. I believe we currently have more information and we have more adherence, especially to the laws, and the laws are more informed. And we are focusing on having the population access to these tests quickly. I believe training the user to use the test is really important. Within the cases that we've seen, They are really efficient and safe tests. However, the poor knowledge of handling or the poor training the user receives causes wrong results. The safety of the test is vital to us. We currently are based on the current normativity and international guidelines that help us to detect HIV. As a commission, we are focused on providing safe, efficient tests that provide exact results for HIV, especially for the population. Therefore, I believe that it is a good thing that we are on the same line because we gain more access and more information. The self-test that we received was really relevant for us because it was done through oral fluid with a solution. So the swab is rubbed against the gums of the mouth, and it has a solution that needs to be used for a certain time, and then we have a reagent strip, and the time to have a result must be within 20 and 30 minutes. It is important to tell the population that they need to wait the time that is necessary. It is important to read the manual, and they need to be able to read during the proper 20 to 25-minute time frame to receive a result. It is an antibody test. So that's why it is important for us as a commission to detect antibodies because we have several types of detection. And they are safe tests that we can do, and they are done at home or at a clinical lab. I don't know if you have any questions or any comments. Thank you very much. I believe your comment is pretty interesting from your perspective as a member of this conference, as a regulating agent. To close this panel, I will give the floor to the Secretary General who will address us. Thank you very much, Brandon, and thank you very much to all of the members of the panel. I want to give a brief summary of the situation that we have in Mexico regarding self-testing and HIV fighting. From CISS, we have an agreement with the Social Security Institute of Mexico to have an epidemiologic model that provides the institution greater quality regarding those who don't know their HIV status. And this helps us create detection strategies. This service is available to all of our members, and we are pleased to collaborate with the Chilean and Colombian, Trinidad and Tobago, and all of the institutions and organizations who are here with us in this panel. A couple months ago, the Mexican official norms that impeded the performance of self-testing in Mexico were modified. Now self-testing are allowed, and from that point onwards, COFEPRIS has worked quickly to have this type of test in Mexico, and I like to provide my recognition to COFEPRIS for their work so that we can have this in Mexico. Also, I congratulate the countries who have helped us with sharing their experiences, not only within the American continent, but also in other latitudes, as we have heard previously. We have the commitment to reaching 2030 and getting this goal of 95% of those with HIV knowing their status. We know that countries such as Mexico and the countries of the continent have the problem of stigmatization. And this is a problem that we are still fighting with courses and with awareness processes, as well as training for those medical professionals. It is a parallel work that will no doubt lead us to reaching this goal in 2030. So, with all this in mind, I also invite you to be on the lookout to this international conference, the third International Congress of HIV. It is at the end of November. We don't have the dates already, but they will be available in time. So please be on the lookout for that. Thank you very much for everyone who's here, either on the headquarters and virtually. I hope that we see you again soon. Thank you very much.